Medurstand Understanding Medicine.
Professor Aziz Rehman for Medurstand-Understanding Medicine. And today I'm going to talk about an approach to acute diarrhea. Diarrhea, is a very common condition, mostly self-limiting, mostly little bit of nuisance, but it could have actually significant mortality and morbidity in young children and in the elderly. So I think an intelligent approach is necessary and you have to decide what to do in what situation. Of course, depending upon the situation, the approach will be different. But this lecture should provide you an overall guideline to deal with such cases. It is defined as watery stool with duration less than 2 weeks because we have used the word acute. So acute would be anything less than 2 weeks by definition, but typically it is just few days. So if somebody has a significant change in the stool consistency, it has become soft or it has become frankly watery, it would be called a diarrhea, even if it is just 1 or 2 stools, typically 2 to 3 stools per day. Because just one stool, perhaps patient will not be bothered and patient will not even come to you. But if there are 2, 3 stools, then patient will be bothered and will seek your advice. So then we will call it formally a case of diarrhea. Then of course every patient would have a different number of stools, different size of stools, so we will evaluate the case and make a judgment. Etiology usually infective. It could be due to many conditions, like it could be use of some purgative or some other condition. So, but mostly it is due to some infection. Unlike chronic diarrheas, I've already made a lecture on chronic diarrhea, and there I emphasize that chronic diarrheas are most likely due to some non-infective conditions, but acute diarrheas are mostly infective. That does not mean that all these patients need antibiotic, because mostly these infections are due to viruses or some self-limiting bacteria. So it is usually due to some infection. And self-limiting, that means infection would not require antibiotic. Of course, patient would require some symptomatic treatment, but mostly the disease will resolve on its own. And you must consider associated symptoms. Diarrhea just refers to the loose motion, frequent loose motion, but patient may have additional symptoms like nausea, vomiting, abdominal pain, fever. So accordingly, our approach changes. And there are different types of actually gastrointestinal infection. In the next slide, I'll just give you some terminology, and accordingly we manage these cases. So food poisoning is typically a case where patient ingested a food which had preformed toxins because of contamination, because the food was contaminated with some germs, and those germs had made some toxins which had effect on the gastrointestinal motility and secretions. And this patient typically, after ingesting that food, patient would typically have a bout of vomiting, maybe just few hours or maybe up to a day, but after ingesting that food, patient would have predominant bout of vomiting. Typically fever and loose motions are minimal. Then gastroenteritis, as the name says, the infection of the stomach as well as the intestine. So patient would have stomach related symptoms like nausea, vomiting, dyspepsia, and patient would also have intestinal related symptoms like abdominal cramps and loose motion. Now dysentery is another type of intestinal infection where patient has predominantly lower intestinal symptom. Patient has frequent defecation, usually small in size, usually associated with tenesmus. That means pain in the rectum. When patient passes stool, there is pain in the rectum, and when patient has already passed stool, there would be feeling as if stool is still present in the large intestine, and patient would feel like going to the toilet again and again. This is indicative of inflammation of the last part of the intestine, and this is usually associated with mucus and blood in the stool. So this would be called dysentery. Any infection could become dysentery, but these people typically have Shigella or Salmonella or E. coli infection. Then cholera or cholera-like condition, and this is another type where patient has profuse watery diarrhea. Now, patient may not have upper GI symptom at all, patient may not have fever, patient may not have any abdominal pain, but patient would have very, very large, frequent, bulky stools, mostly consisting of water, and this is because of some toxins produced by cholera bacteria and also some toxigenic form of E. coli. So they actually, through a specific mechanism, which I'll explain later, they produce a lot of watery diarrhea. So I hope you are able to differentiate between 3 or 4 different types of gastrointestinal infection, and accordingly we label them, and treatment approach is slightly different. For example, in food poisoning, you may not do anything, just give some treatment to control vomiting, and a patient is going to recover on its own. Whereas in this condition, main treatment would be replacement of fluids and electrolytes. So mechanism of watery diarrhea in cholera or cholera-like condition. So I'm going to explain because this is important. The toxin which is produced by cholera, and cholera would be taken as a prototype, but toxigenic E. coli can produce very similar symptoms. So cholera will produce a toxin which stimulates adenyl cyclase in the intestine, and that increases cyclic AMP formation. And the function of cyclic AMP is to produce chloride. So lot of chloride will be secreted into the intestinal lumen. Now, of course, chloride will take with it sodium and potassium and bicarb. Okay, so patient will lose water, patient will lose sodium and chloride, and patient will lose potassium and bicarb. This has got a lot of implication on the pathogenesis and the treatment. So as far as stool is concerned, it is isotonic from sodium and chloride perspective. That means patient would need replacement with sodium and chloride water saline, but the stool is hypertonic from potassium and bicarb perspective. So patient would develop deficiency of potassium and deficiency bicarb, resulting in hypokalemia and acidosis. So I think when we treat, these factors have to be considered. Since there's large amount of fluid loss, so there will be a lot of depletion of potassium and bicarb in the body. So this would cause dehydration, hypokalemia and acidosis, and this could lead to hypovolemic shock. Of course, early recognition, early intervention would prevent hypovolemic shock, but unfortunately, many people, they do not have access to healthcare, and they still end up having hypovolemic shock. It's so tragic, and that in 21st century people just dying of something which is very easily treatable. So I think that puts us as a doctor under a lot of responsibility and pressure. So how does this pathophysiology mechanism translates into the treatment? Main mortality in this type of diarrhea is due to fluid and electrolyte deficiency and secondary renal shutdown and hypovolemic shock. And the treatment, the mainstay of the treatment is fluid and electrolyte replacement. And antibiotics have minimum or no role. In cholera, antibiotics are used, but there is no convincing evidence that they actually prevent death. Mainstay is to replace electrolytes and water. So you need to develop a skill to estimate fluid losses, and you can check electrolytes and then replace accordingly, because this condition can affect people in any situations and there could be epidemics. So scientists have developed some sort of formulae on the basis of which you can actually have an idea without measuring, or you can replace potassium and bicarb and fluors saline according to your judgment rather than based on laboratory tests, because in many situations, particularly during epidemics, these laboratory tests may not be available. So this was the watery diarrhea, which typically occurs in cholera. Infection itself is self-limiting, and with time cholera will die off. But you have to take care of the fluid. Now we're going to discuss another type of infection and pathogenesis. That is pathogenesis of bloody diarrhea. Diarrhea associated with blood or tenesmus or fever or abdominal pain. So where it is primarily the infection. So ingestion of cytopathic E. coli or Shigella. Although Shigella is historically known to be the cause of dysentery or bloody diarrhea, but it is still common. But many E. coli, especially the cytopathic type, E. coli has got many types. The cytopathic type is the one which actually invades tissues and kills endothelial cells, epithelial cells of the colon, and also the small intestine. So there is intense inflammation. So this is actually actual infection. In the true sense, this is the actual infection because bacteria invade the tissue. There is intense inflammation, and sometimes it may lead to ulceration in the intestine and the small gut or the large gut. And this would result in fever, because whenever there is infection, whenever there is bacterial invasion, there could be bacteremia, and bacteremia would cause fever, and there may be abdominal pain, and there may be abdominal tenderness because colon or small intestine is actually inflamed, and there may be tenesmus. Tenesmus means the patient feels pain in the rectum while passing stool, and patient would have the feeling as if the stool is still present and in the gut, in the large gut after defecation, and would feel like going to the toilet again and again. And this indicates actual inflammation of the terminal part of the intestine. And this may result in bacteremia and endotoxic shock. You know, infection would cause a lot of diarrhea, but this diarrhea is usually small size and mostly associated with mucus and blood. But it may not cause very significant fluid or electrolyte losses. It would mainly be responsible for bacteremia and endotoxic shock. Now, I don't say that majority will end up here. In fact, majority will recover on their own without any intervention, but some small percentage would develop bacteremia and endotoxic shock that can be prevented by early intervention. Now, how this pathogenesis translates into treatment, I'm going to show you in the next slide. Main morbidity and mortality is due to bacteremia and endotoxic shock. Endotoxic shock is a unique condition which is caused by a gram-negative bacteria. Gram-negative bacteria have certain endotoxin in their cell wall. Now, because when this endotoxin is released, they have certain effects on our vessels and other systems. So they can cause a lot of vasodilatation, and there could be an irreversible shock, endotoxic shock. So once shock sets in, then you will have to focus on the shock. Then just giving antibiotic is not going to be enough. So I think early intervention, if you think patient is toxic, again I say many patients would not need an antibiotic, but somebody who has tenesmus, somebody who is passing blood-stained stool and has got fever, I think that person must be given an antibiotic, and you should decide early, because before endotoxic shock sets in. So early and effective antibiotic is crucial in these patients. So although both are classified as diarrhea, but pathogenesis is different, so the treatment approach would be different. Now, this is the etiology. Actually, this is not the complete list. Preformed toxins from Staphylococci and E. coli. This is the cause of food poisoning. Certain viruses like norovirus or rotavirus in children, that may be responsible. E. coli, toxigenic. Toxigenic E. coli are those which produce toxin and that can cause watery diarrhea. Or cytopathic E. coli, the one which invades tissues and cause inflammation, pain, and they cause bacteremia and endotoxic shock. Shigella is responsible. Salmonella, many salmonella are responsible for typhoid that I have covered in another lecture, but some salmonella would just cause gastroenteritis. Entamoeba histolytica would cause very similar symptom, although fever would be less because this is parasitic infection, and very similar to Entamoeba histolytica, there is Giardia lamblia. Now, these are some common infection which we see in immunocompetent people. In immunocompromised people, people with HIV, people with other infection, other diseases like people on immunosuppressive therapy, they may have infection due to some unusual, uncommon organism. So you need to keep a high index of suspicion. When we are treating immunocompetent people, we decide about the antibiotic on empirical basis. But if somebody falls in a immunocompromised status, that group, I think we need to have, mostly I think we should have isolation of the organism and culture if possible. Now, in the initial assessment, these are the things you need to do, and this is, we're talking about the history. When you take history, I think you should have an estimate of fluid losses. How do we do that? Duration, how long patient has been having this diarrhea, number of motions per day. Patient could have sometime 20 or plus motions per day, sometimes just 2 or 3. Accordingly, the fluid losses will be different. Size of the individual motion, patient will say it is large volume, 300 ml, 400 ml, or sometimes it may be just 30 ml. So water content of motion, motion means stool. If the stool is purely watery, or if it is mucoid and has got stool debris, only small amount of water. If there is associated nausea and vomiting. Now, there is double significance of nausea and vomiting. One is if patient is having actual vomiting, that would contribute to fluid losses. So patient is losing fluid from both ends, so that would increase the problem. Another thing is that if patient is not vomiting but just have nausea, that would prevent the compensatory water intake. Even if patient is not prescribed anything, I think as a reflex mechanism, if patient is losing water through the lower GIT, he would probably be tempted to drink water. So if there is nausea, that will prevent that compensatory mechanism also. So if patient has been taking fluids and ORS, and how much patient has been passing urine. This is extremely important. Now, if during history you ask the patient, and if the patient can't even recall when he or she passed urine last time, that means the problem is already ending into serious phase. That means patient is getting into renal shutdown. So I think these would give you a reasonable idea how much fluid patient has lost and how urgent it is to replace fluid, and accordingly you will either hospitalize the patient and start IV fluid replacement, or you will give advice and send the patient home with fluid replacement regimens. After history, you of course need to examine the patient, and in examination what you test is skin turgor that would reflect the dehydration, status of mucosa. If the patient has got dry eyes, dry lips and trunk, that would mean a lot of dehydration. Blood pressure, now please be aware that blood pressure is maintained till very late. So if blood pressure is normal, don't have a very false assurance that there is no dehydration. But if blood pressure is low, that of course means there is very, very severe critical dehydration. Pulse might become fast and steady, and there may be altered sensorium. This is very, very important. If patient has got altered higher mental function, without the use of any sedatives or antiemetics, because antiemetics can also affect your sensorium. If patient has got uh, uh, impairment of higher mental function, that means the brain circulation is affected. You know, our brain has got preference over rest of the body as far as blood circulation is concerned. So if brain circulation is affected, that again would mean very serious dehydration. So accordingly you take a prompt action. So laboratory tests, I think we always start with CBC. In cholera or profuse watery diarrhea, CBC may be normal. In other types, in infection, in dysentery, you would expect some leukocytosis with the with neutrophilia. And serum electrolytes, you will test in all patients who have watery diarrhea. In the initial phase, you may have normal potassium, normal blood gases, normal bicarb, despite significant depletion of these electrolytes. Because body has a mechanism of moving intracellular potassium, intracellular electrolytes, and regenerating bicarb to maintain their levels. So if you have hypokalemia and acidosis, that would mean you are already somewhat late. So don't waste any further time to start replacing these electrolytes. Kidney function tests, there could be a kidney disease in the background, or there could be secondary renal shutdown. So there may be what we call pre-renal azotemia. Pre-renal azotemia means that kidney function is slightly deranged because of poor filtration, because there is dehydration, there is less glomerular filtration, and that is why kidney function is slightly deranged. But once we replace fluid, then these will become normal. But this pre-renal phase can end up into renal phase, then the situation will become much more complicated. ABGs, I think only the sick patient would need ABGs. So on ABGs, you may expect abnormalities related to bicarb and pH. There may be acidosis, metabolic acidosis, and the new ABG machines, they also give you sodium, potassium, and HB. So I think you will have more comprehensive report from the newer machine. So stool examination, this is important. I think you would probably think that every patient should have stool examination. Maybe you are right. But in my own practice, I mostly do not go for stool culture or stool examination, because I think in majority I can make a reasonable clinical judgment which type of infection this patient has and which antibiotic this patient would benefit, because this would save time and this will also save inconvenience, and this would also reserve the resources. But in epidemiology, during epidemics, I think, and if patient is very sick, otherwise, then you definitely need to do stool examination. In stool examination, you would look for pus cells which have ingested bacteria or parasites, or presence of mucus and all these things. And you would probably like to order stool culture, since stool is normally full of organisms, so stool culture never returns negative. You would be particularly interested in E. coli and Shigella and Salmonella. So I think, and if you can isolate those organisms, then of course you would also know the antibiotic to which these organisms are sensitive. So stool culture, particularly Shigella and Salmonella. Others as relevant, because patient may have comorbidities, patient might have got some complications, so further tests would be needed. For example, if you suspect the patient has developed respiratory pneumonia as a complication of gastroenteritis, or joint arthritis, or arthritis of the knee joint, then of course further tests would be needed. Now the treatment first and foremost is the fluid replacement, especially if patient has got watery diarrhea, oral rehydration solution or equivalent. IV fluid replacement if indicated with ringes and normal saline. Of course, fluid replacement is always needed, but I just mean if IV is needed, then we give ringgers or normal saline. Otherwise, we will replace with oral fluid called oral ORS, oral rehydration solution. This ORS, which is recommended by WHO and used all over the world, provides a very convenient way of replacing fluids and electrolytes. And it has got a certain composition. It comes in powder form or sometimes also in the bottled water form. But I think this powder is better because it has more shelf life. So it has got this combination: sodium chloride 3.5 gram, trisodium citrate 2.9 gram, potassium chloride 1.5 gram, and glucose 20 grams. You don't have to memorize these numbers, just make sure that you know the composition and the philosophy. Now I'm going to explain the philosophy behind this composition. Sodium, of course, needs to be replaced because patient has lost sodium, and chloride also goes with the sodium, so this is important to be replaced. Trisodium citrate actually is a substitute of bicarb. We need to replace bicarbs, but bicarb once dissolved in water does not remain stable for a long time. So trisodium citrate after dissolved in water remains stable, so I think more practical to be used in remote areas. So this works as a bicarb replacement. Potassium chloride, if you remember, I told you that patient is losing a lot of potassium, patient would develop hypokalemia, so potassium needs to be added, and glucose is added for a very interesting reason. Of course, these patients may develop hypoglycemia and glucose will prevent that, and this would provide some nutrition also, but that is not the main reason why glucose is added to this ORS powder. You know, there are two mechanisms for sodium chloride water absorption. One is the main one, which gets blocked in cholera infection. So sodium and water will not be absorbed through its normal main channel. But nature has made an alternate mechanism for sodium absorption, that is glucose dependent absorption. So that means whenever one molecule of glucose is absorbed, it would carry with it one sodium molecule also, and sodium will take chloride with it, and sodium chloride will take water with it. So by giving glucose, we ensure that through the alternate mechanism, sodium, chloride and water all are absorbed. So that is why glucose is added. Please note down that there is no glucose free ORS, because that will be against the very concept. Of course, if patient does not have severe problem and patient is diabetic, maybe you can make your own replacement fluid without glucose, but the actual this ORS has glucose in it for this reason. There are two formulations. This is the main one, the regular one, 20 grams of glucose, 90 milliequivalents of sodium, 20 milliequivalents of potassium, 30 milliequivalents of bicarb, and the osmolality is 310. Please note down that potassium is much more that is present in our extracellular fluid. Similarly, bicarb is also more than that. And this is because we expect deficiency of these two and we want to replace them. Because somebody has also made another, the low osmolality. This 310 is slightly on the higher side. Now people have come up with another formula which has got lesser glucose and lesser sodium. Other things are the same. It has got osmolality of 245. Now there is some evidence that this low osmolality ORS is less likely to induce nausea and is more likely to control diarrhea because of its low osmolality. I'm not sure if currently this is available in our country, but we still use a regular ORS. If somebody does not have access to ORS, he or she can take any water with salt added, with soda bicarb added to it, and maybe some flavoring agent to make it more palatable. And this whole sachet is mixed in 1 liter of fluid, and that can be taken as per patient's requirement. So I think this is important. Now let's talk about the role of antibiotics. Antibiotics may not be needed, though we feel tempted to give antibiotic, though patient will also expect antibiotic. But I tell you, if patient has no fever, patient does not have bloody diarrhea, patient does not have abdominal tenderness, and patient does not have leukocytosis, and patient also have nausea and vomiting, I'm sure most of these patients can be treated without antibiotic. But if you want to give antibiotics, ciprofloxacin is prototype and very effective antibiotic. I think it can be given 500 milligram twice a day for 3 to 5 days. And now this is the adult dose. For children, of course, the dose will be different. But just note down, I have written 3 to 5 days. Typically, antibiotics are given for 5 days. But if you give early antibiotic, then 3 days may be sufficient in gastroenteritis, because you just want to have a local effect, and these patients typically they respond very fast. So I think 3 days course may be sufficient, but use effective dose, that is 500 milligram twice a day for adults. If you're not sure if this is bacterial infection or protozoal infection, then you could add metronidazole. This is actually a very effective medicine for amoebiasis and giardiasis, and it would also be effective in gram-negative infection. So metronidazole can be added 400 milligram 3 times a day for 5 days. In Pakistan, we have 400 milligram preparation, although literature sometimes mention 500 milligram. We don't have 500 milligram preparation, but our people respond to 400 milligram very well. Antidiarrheals, if patient is having very frequent loose motion, patient would expect some relief. So these are the drugs. There's something called Imodium. It has got loperamide, and you can give 2 capsules three times a day. And this would control diarrhea. You can give up to 10 or 12 capsules, but don't give too many because they could cause paralytic ileus. And you should particularly avoid these antidiarrheals if patient has got bloody diarrhea, stool and blood in stool, or patient looks toxic, or patient has got abdominal distension and is tenderness and tenesmus. Then you should avoid giving loperamide, because loperamide stops further fluid secretion and also reduces intestinal contractility to a certain extent. So this may cause paralytic ileus, or may also cause bacteremia, toxemia. So loperamide is ideal for those patients who are not toxic, who do not have fever, but has got a lot of watery diarrhea. So they can be given and they would benefit from this. There's an alternate salt called erasicadotril, and this is available in the name of Hydrasec. This has got less effect on motility, and this has predominantly effect on secretion. So I think maybe this is better, this is safer, but this is also good. Then in children particularly, there's something called Smecta. This is actually a fluid absorbing, and chiopectate, bismuth subsalicylate, and they would absorb extra fluid from the diarrhea from the stool and will make motions less frequent and fluid losses will be minimized. So any one or combination you can use based on your experience and patient's preferences. Now we are coming to the end. If patient has got vomiting, because patient may have just diarrhea or fever, then you would add antiemetics. And Antimax ondansetron is very effective. It can be given intravenously or orally. If patient is having a lot of nausea, you can start with intravenous or intramuscular and later on move to oral. Or metoclopramide is also available, that can be used intravenously or orally depending upon patient. So those patients who have fever, I think simple paracetamol may be sufficient for those patients. So that is all about approach to acute diarrhea. This has been Professor Aziz Rehman from Medurstand-Understanding Medicine. I look forward to see you in my next video lecture. Thank you for joining. Professor Aziz Rehman.